We'd like to welcome everyone to this webinar on prostate cancer. We're just waiting till the participant number goes up and Dr. Asbach will introduce the ICIS and the upcoming webinars, and then we'll start our lectures right after that.
So welcome to this webinar. On behalf of the International Cancer Imaging Society, it's my pleasure to welcome you today. We have actually participants from more than 35 countries. I think this underlines the importance of prostate MRI in clinical practice worldwide. I will now start with some remarks on prostate cancer tumor detection before I hand over to Dr. Fennessy, who will speak about tumor delineation. These are my disclosures. I have no conflicts of interest to declare. So talking about prostate cancer detection by MRI is actually a three-step approach. You have to use the appropriate MRI protocol, which should be PIRATES compliant. You have to assess and reflect the image quality you get. And the most important point, obviously, and I will talk about this in more detail, is scoring the likelihood of clinically significant prostate cancer via the PIRATES score. Keep in mind that the strength of prostate MRI is this high sensitivity to detection for clinically significant prostate cancer. Depending on the study you read, you're in the 90% range. And the high negative predictive value of prostate MRI, which is, again, which study you read, around about 95%. And the third strength of prostate MRI is when you incorporate MRI in this MRI pathway, you reduce the number of detection of clinically insignificant prostate cancers. So this is a very important advantage of prostate MRI. Just briefly mentioning the appropriate prostate MRI protocol. Again, it has to be PIRATES compliant. So you have to acquire two-plane T2-weighted imaging. You have to acquire a diffusion-weighted sequence and dynamic contrast enhanced imaging. This is just an example of a normal prostate MRI T2-weighted images. On the left, you see axial slices. On the right, you see coronal slices. And you can nicely delineate anatomy of the prostate. The second MRI sequence is obviously diffusion-weighted sequence. Again, this is a T2, and what we do is we acquire a p-value of 0 to 100, an intermediate p-value of around 400 to 600, and then a high p-value of about 800 to 1,000. And then we compute the ADC map and calculate a high p-value, which is shown here. So this is the crucial sequence for prostate MRI. And the third column of prostate MRI is contrast-enhanced imaging. Again, on the left, you see a T2-weighted image. On the right, you see this GCE sequence. It's usually a gradient echo sequence and continuously acquired after contrast medium application. This is an image from the early arterial phase, and you see the prostate cancer lesion showing focal early enhancement. This is, again, a crucial sequence for prostate MRI. You could also compute the signal intensity. I put a ROI into this cancer lesion and compute the signal intensity over time. So you'll see the typical contrast enhancement in the early arterial phase of prostate cancer and then a washout. So this, to sum up, is the third column of prostate MRI. As I said, you have to assess image quality. I will not go into details. I just briefly want to mention that a new PyQual version, the version number 2, has just came out a few weeks ago, and it's mandatory for prostate MRI to score the image quality you get, because in the sense of low image quality, obviously the scan probably needs to repeat it. So that's a crucial step in prostate MRI. Now I would like to talk about the detection purpose of prostate MRI, and international standard is PIRATES scoring, so scoring the likelihood of clinically significant prostate cancer. And by doing that, you have to keep in mind that there is a different zonal origin of prostate cancer. This is a normal prostate MRI scan. On the upper left, you see axial T2 weighted image. This is a coronal T2 weighted image. This is the high B value image from the diffusion, and this is the ADC map. And this is a normal prostate MRI scan. You see this enlargement of the transition zone. You nicely delineate the peripheral zone. We have some linear T2 hypointensities, which we find in many, many cases. And I'm showing this image to underline the potential of prostate MRI to show this zonal anatomy of the prostate, transition zone, peripheral zone, also the central zone at the base of the prostate, and the anterior fibromuscular stroma. And keep in mind that prostate cancer is the likelihood is depending on the zone, and there are typical characteristics of each zone, which I will talk about in a minute. And importantly, most prostate cancers origin from the peripheral zone. Depending on what literature you read, I put the numbers from the PIRATES document. It's about 70 to 75% originate in the peripheral zone, and 20 to about 30% in the transition zone. Rarely you'll find prostate cancer arising from the central zone, and you never find prostate cancer arising from the anterior fibromuscular stroma because it does not contain glandular tissue. Sometimes the fibromuscular stroma is invaded by prostate cancer, but it cannot be the origin of prostate cancer. So most prostate cancers can be found in the peripheral zone. And then we have to score the likelihood of the presence of clinically significant prostate cancer via PIRATES. I guess most of you know that and use this already in clinical practice. We assign a score of 1 with a very low suspicion to a score of 5 with a very high suspicion of prostate cancer. I will not talk about PIRATES in detail. I will now continue on showing you images. Just briefly mention the concept of the dominant sequence of PIRATES. Either the peripheral zone or the transition zone has a different dominant sequence. The peripheral zone, the dominant sequence is diffusion-weighted imaging. This is very important. And only in the context of a PIRATES 3 lesion, information from a second sequence, in this case, the DCE sequence, comes into account. In all other instances, the dominant score equals to the final PIRATES score. And the same nearly applies to the transition zone. The dominant sequence is a T2-weighted sequence, and in PIRATES 3 and in some PIRATES 2 cases, information from the diffusion-weighted sequence comes into account to account for the final PIRATES score. So keep in mind the concept of the dominant sequence. I will comment on this when showing the images now. So we start off with peripheral zone prostate cancer, and all my slides are shown like this one. So I show you a T2-weighted sequence on the left. I show you an ADC map. I show you a high B value image, and I show you in many cases a DCE sequence. And this is a typical case of prostate cancer in the peripheral zone. So we see this nice T2 hyperintense signal of the normal peripheral zone, and we see a focal area of decreased T2 signal in the peripheral zone, in this case, left anterior peripheral zone. This is a typically area for prostate cancer in the peripheral zone, as I said. And on the ADC map, you see marked diffusion restriction. So you see a signal drop on the ADC map. And this mirrors with the high B value image, where you see bright signal intensity in the lesion. And on the right, it's the DCE sequence, again, early arterial phase. And you can see focal early enhancement in the lesion. So these are the typical imaging findings of peripheral zone prostate cancer. Show you a companion case. This is a patient with a prostate cancer in the peripheral zone on the right apical side of the prostate. Again, on the T2 weighted image, you see an area of decreased signal intensity. Please note that the contralateral side also shows some T2 signal abnormalities. On the ADC map, again, you see marked diffusion restrictions. So you see low signal on the ADC map. And mirroring on the high B value, you see bright signal intensity in the lesion, which also shows the marked diffusion restriction at the right apex of the prostate. And on the right, you see the DCE image again, and you can see that there is focal early contrast enhancement. So this is again, this case, a 15 millimeter Pirates 5 lesion in the peripheral zone at the apex. The last two cases were relatively obvious cases of prostate cancer in the peripheral zone. In clinical practice, many of you know that the lesions are much smaller. And this case actually shows a small lesion, which is not that easy to delineate. On the left side, again, you see the T2 weighted image in the axial slice. It's really hard to delineate a lesion here. If you look at the coronal T2 weighted sequence, you see an area of decreased T2 signal in the right apical region again. And on the ADC map, it's not that easy to delineate the lesion as well, but there is an area of decreased ADC in this area, and it's probably better seen on the high B value image again. So there is an anterolateral area here. And if we go back to the T2 weighted coronal, we see that this lesion actually grows along the capsule. This is a typical pattern of prostate cancer with a growth pattern parallel to the capsule. And on the axial slices, you are in a partial volume averaging effect because of the configuration of the lesion. And that is the reason why it's not that obvious on the ADC map. It's not that obvious on the axial T2 slice. So the best sequence after the coronal T2 is the high B value image to delineate this lesion. As I mentioned when talking about Pirates briefly, DCE positivity or focal early enhancement is an important criterion in Pirates 3 lesions of peripheral zone prostate cancer. This case underlines this. So this is a patient who has a relatively small prostate without obvious BPH changes. And we see a almost homogeneous low T2 signal intensity of the peripheral zone. This is a coronal image again. You see both sides of the prostate on T2 show decreased T2 signal intensity. On the ADC map, you see some area here in the right anterior part of the gland with some diffusion restriction. On the high B value image, again, it's not that obvious. So these are typical inconclusive findings on T2, and no black and white pattern, no area of marked diffusion restriction on the diffusion weighted sequence, accounting for a Pirate 3 lesion. And in this context, DCE imaging comes into account in the peripheral zone. And this is, again, early arterial acquisition. And what we can see is an area of focal early enhancement corresponding to a Pirates 4 lesion, because it's a definite focal early enhancement. And this accounts for a Pirates 4 upgrading, and this patient subsequently underwent MRI-guided biopsy, and this was a Gleason 4+3 prostate cancer. So this case, to summarize, shows DCE positivity to upgrade a Pirates 3 to a Pirates 4 lesion based on focal early contrast enhancement on the DCE sequence. Now I would like to switch to transition zone prostate cancer, which is more challenging. And I would like to start with a normal case of transition zone. So this is a patient who has a typical BPH changes of the transition zone. Axial T2 weighted image again. And what we see is this typical pattern of BPH. We call it organized chaos, where we see multiple nodules which are round to ovoid. They have a T2 low signal intensity rim and a heterogeneous signal quality on T2 with some areas of bright signal and some areas of dark signal. So this is what we call organized chaos, which is typical for normal BPH findings. The middle image again shows the ADC map. So there's no area of marked diffusion restriction mirrored by this high B value image. There's no area of increased signal, so no abnormality on the diffusion weighted sequence. In contrast, on the bottom of the slide now, I show you a typical prostate cancer case in the transition zone. What the typical finding is homogeneous low T2 signal intensity in the transition zone. So you can see this area, which is compared to the contralateral area, homogeneously low T2 signal. And it's more obvious in many cases, like in this case on the diffusion sequence on the ADC map, you see correspondingly an area of low ADC, and on the high B value image on the far right again, you see an area of marked diffusion restriction. So this is the typical appearance of prostate cancer in the transition zone. So this organized chaos that we have on the typical BPH is actually replaced by these homogeneous low T2 signal intensity changes, which is also referred to as erased charcoal sign. This is a companion case of a transition zone prostate cancer. On the left, you again see an axial T2 weighted scan, this coronal one, and you can delineate again this area of erased charcoal, low T2 signal intensity change, which is probably even better delineated on this coronal scan when you compare it to normal transition zone here on the right base. And on the right, again, you see this ADC map and the high B value image. And in many cases, the shape of the cancer in the transition zone has this typical lenticular shape. So you see this typical lenticular configuration of the cancer, which accounts for a Pirates 5 lesion in this case in the transition zone. But it's not always that easy, and that is why I put this case into the talk. And one important finding in the transition zone is ill-defined borders. So again, this is an axial T2 and a coronal T2, and this patient has a much smaller transition zone prostate cancer, which is located on the left. And on the contralateral right side, we see a typical BPH node. So the BPH node typically shows a round shape, heterogeneous signal intensity, and it is well defined. You can basically circle the lesion. So that's a typical BPH node. When you now look at the contralateral side of the transition zone, you see this area of low T2 signal, which is not well delineated. It's ill-defined. You cannot really contour it well on the T2, especially in the coronal as compared to the contralateral side. And then to gain conspicuity, look at the diffusion sequence again. ADC map, you see an area of marked diffusion restriction. On the high B value image, you see high signal in the B value. So this corresponds to this black and white pattern of prostate cancer. And this accounts for a Pirates 4 lesion in the left transition zone. And this actually was biopsied, and biopsy showed a Gleason 4+4 = 8 prostate cancer on the left transition zone. In patients that have undergone biopsy prior to MRI, which did not show prostate cancer, we often find transition zone prostate cancer in the anterior part of the prostate because it's undersampled by randomized biopsy. This case shows such a lesion. So again, axial T2 weighted sequence, we see the typical organized chaos of the transition zone, but in the anterior part of the gland, we see this low T2 signal intensity change here, which corresponds to marked diffusion restriction on the ADC map again, and mirrored on the high B value image, we see high signal intensity, again accounting for the black and white pattern on diffusion weighted imaging. So this is an anteriorly located transition zone prostate cancer. Again, these are often missed on randomized biopsy, and MRI, which then subsequently is performed, shows the lesion quite nice. And now fusion biopsy can be performed and actually confirm prostate cancer in this case. This is a companion case, challenging case, much smaller lesion in the left transition zone, again, lenticular shaped, and again showing the black and white pattern on diffusion with high signal on the high B-value image and low signal on the ADC map. I'm showing this case to show the anterior fibromuscular stroma again, which is located anteriorly midline. It also shows very low T2 signal, and because of this low T2 signal, it also appears dark on the ADC map, but it does not show high signal on the diffusion-weighted high B-value image. And because it doesn't demonstrate true diffusion restriction. So do not confuse the anterior fibromuscular stroma with a cancer lesion as highlighted here. And so always look at the high B-value image, and you have to show, have to reflect this black and white pattern unless it's not true diffusion restriction. As I said, transition zone prostate cancer can be quite challenging, especially in small lesions. This case underlines it again, an axial T2 weighted and a coronal T2 weighted scan. This is a calcification, but there is an area very close to the urethra, which shows T2 signal reduction, also seen here on the coronal slice. And again, it's a very small, difficult to delineate lesion, but look at the diffusion again. On the ADC map, you see marked diffusion restriction, and on the high B-value image, you see this area of increased signal again. So again, small area of black and white pattern, and is corresponding to this really small area in the transition zone. And this turned out to be on fusion-guided biopsy, also a clinically significant prostate cancer. At the end, I would briefly talk about the mimickers of prostate cancer. And there are basically two main mimickers that we focus in daily clinical practice. On the left upper image again, this is a T2 weighted sequence, quite confusing image with organized chaos, but also areas of dark T2. And on the ADC map, you see a small area of marked diffusion restriction here, which corresponds to a small area of very bright signal on this high B-value image. So again, a small area of black and white pattern on diffusion, which makes the lesion very suspicious of prostate cancer. But if you carefully match it to this confusing anatomic T2 weighted image, you end up in this area of high T2 signal. And high T2 signal is not typical for prostate cancer. On the right bottom of the slide, I put a T1 weighted image, and you can actually see in this lesion high signal on T1, corresponding to this area here. And this is basically a very small intraprostatic abscess containing pus that shows high T1 signal. And because it's obviously filled with fluid, it shows a high signal on T2. So always mirror your finding on the diffusion with the T2, and do not forget the T1 weighted sequence. And the second mimicker of prostate cancer is severe prostatitis, in this case, granulomatous prostatitis. On the left image, again, T2 weighted axial sequence, you see areas of low T2 signal in the peripheral zone. These areas show, again, a black and white pattern on diffusion, marked diffusion restriction, low signal on ADC, high signal on the high B value. So this is, again, Pirates 5 changes of the entire peripheral zone, basically. But you cannot distinguish this from severe granulomatous prostatitis. So you have to score it as a PIRAS 5 and discuss with your clinicians whether this needs to undergo biopsy, which will probably be the case in most cases. But granulomatous prostatitis can mimic prostate cancer. And if you do the biopsy and you get back severe granulomatous inflammation, it basically is the correlate for your MRI finding. So I'd like to summarize. Cancer detection is a three-step approach. Use the appropriate PIRATES compliant protocol. T2, diffusion weighted, and DCE imaging. Reflect image quality, because low image quality does not allow to exclude prostate cancer. And then score the likelihood of clinically significant prostate cancer using the Pirate system. And remember that there is a zonal occurrence of prostate cancer, with most cancers originating from the peripheral zone. Second, most cases originate from the transition zone. With this, I'd like to thank you for your attention and now hand over to Dr. Fennessy, who will now talk in more detail about tumor delineation. Thank you very much.
Thanks, Patrick. Okay, so I am going to share my slides here. So I'm going to now focus on tumor detection and tumor boundary definition, really focusing more on the science of it and the correlation with the histopathology. So as Patrick was saying, the vast majority of prostate cancers are low grade, and men will never really die of the disease. And if we can figure out how to find those who will die of the disease versus those who will not die of the disease, we will save a lot of morbidity, mortality, and save a lot of money. This is an estimation in the US, actually from a number of years ago, so I'm sure it would save a lot more right now. So to really understand where MRI helps, it's a good idea to understand the pathology of prostate cancer. So the Gleason pattern scale that I am showing here on the right, the little green at the top, number 1, if you like, that's what you would normally expect. So there's a lot of lumen, there's a lot of hole, if you like, in the middle of these little circles. And that's what you'd expect from normal glands to maybe some well-differentiated cancer, meaning it's very similar to the normal pattern. And then as you go through from 1 to 3 in this Gleason pattern, you completely lose the normal architecture and you get these sheets of cells. So no real lumen left there, just these sheets of cells. So this risk stratification really is just loss of the normal glandular tissue architecture. And we are moving from Gleason score to ISUP, which is the International Society of Urologic Pathology. And again, it's the predominant pattern, the 3, what we normally see. And then if there is a secondary pattern of something that's a little worse, that's also there, or something that's a little better. So it could be more of the 4, a little bit more of the 5. But what is the predominant pattern and the secondary pattern? And what we now use is ISUP. So anything that's group 1 or 2 is really considered non-significant or non-clinically significant prostate cancer. Once you hit into grade group 3 and above, you're really then hitting into something that absolutely has to be treated. The problem is that if you look at, the actual progression-free survival, when we look at between Gleason 3 plus 4 and 4 plus 3, this looks really similar. 3 plus 4, so that's predominantly 3 with a little bit of 4, versus Gleason 4 plus 3, which is predominantly 4 with a little bit of 3. They both add up to 7, so what's the difference? The problem is the progression-free survival is really quite different between the two if these were left untreated. And the other issue is that these are approximately 40% of new cases diagnosed each year. So the role that MRI has to play really has to help us differentiate this 3 plus 4 versus the 4 plus 3, because they've a clinically significant different outcome. And can we really do this? So when we look at the MRI parameters that we use, so Patrick went through predominantly diffusion, which is the poster child for the peripheral zone cancers. And diffusion is really based on the hypercellularity, where you have a lot of cells closely, densely packed together, an enlargement of the nuclei. That restricts the water flow through the cells in the area of tumor, and you get this area of restricted diffusion. The more densely packed the cells are, the lower the ADC number, the darker, the blacker it looks. We also have T2, which in this case here you can see really nicely outlines the tumor. compared to the rest of the peripheral zone. And then we have the DCE, which is based on changes in microvasculature. So this is a really obvious case. I think anybody could see this one. But the problem is that a lot of cases where we call them PIRADS 3, we have, you know, we try to optimize our techniques, but for some reason, sometimes due to patients, due to the coils, due to motion or whatnot, we get a lot of artifacts, and it's actually hard to read a lot of the cases. There's something that may be there, something that might not be there. So in this case here there's something actually in this area here. The PSA in this case was very high. It was a 13.1, and it was read as a PIRADS 3 because if you look, it's not really that obvious where the case is. The problem is that this case in particular was a Gleason 4+3, so it was clinically significant and the patient had to be treated. So this is a not so obvious case. So MRI, while we try to optimize it as much as we can, we try to train ourselves in PIRADS so that we're more definitive and we're not on the fence with PIRADS 3. The problem is that MRI does miss some cancers. And it's thought that, you know, the percentage of cancers, of clinically significant cancers, which are the ones that we do not want to miss, we are missing those. And is it a problem with the radiologist? Is it that we don't have enough training? Or is it really a problem with the MRI? In that it is as good as we can possibly get. So I'm going to show you two cases here, case 1 and case 2. Let's look at case 2 first, just because it's so obvious. So this is a case that had an MRI, and then the patient went to pathology and we did whole man pathology. So everyone can really see this nicely defined tumor here in the left peripheral zone. Which corresponded to restricted diffusion and enhancement. And, you know, you could see it on the H&E sections as well. Case 1 is one that we encounter probably every day with this sort of linear type striations and nothing definitive jumping out. The ADC is full of artifact. It's something that we face on and off. But, you know, this patient did undergo random biopsy on case number 1. And you can see with these pen marks here that the pathologist put in that there was tumor here, there was tumor here, there was tumor here, there was tumor here. But it's really not that obvious to us when we look at the MRI. What's interesting, though, is if you look again at case 2, so case 2 is here, and this was our tumor over here. In the area of tumor, it was 4+3, and it was full of 90% tumor in this area. So when they looked at it on pathology, the composition of that area was 90% tumor and just 10% normal cells. And it was, you know, the percentage of Gleason was predominantly Gleason pattern 7. So, Gleason pattern 4, 70%. So it was pretty obvious to see. When you look at case number 1, when the pathologist looked at the amount of normal tissue and the amount of tumor cells within the areas that they outlined, the problem is that the normal tissue composition was much higher. So we have a tumor with normal interspersed cells, making it really difficult for us to see on MRI. And the problem with this is that not only was there predominantly Gleason pattern 4, there was also an element of 5. So potentially this is actually a clinically or a pathologically worse case number 1 versus case number 2. We can see case number 2 because it's a densely packed tumor with very little normal tissue, whereas case number 1, there's interspersed normal tissue, and we know that prostate cancer is very heterogeneous, and case number 1 was extremely difficult for us to see. So it's not that the radiologist missed it, it's actually really difficult for us to see due to how MRI actually works. So this was a sparse tumor here on the left, meaning it was normal interspersed with tumor, and this was a dense tumor. So it's pretty easy for us to see. So why is it easy for us to see? So we know that the ADC correlates with the percentage of tumor or cells within an area. So if you have a small number of cells, even tumor cells, even if they're aggressive cells interspersed between normal, the ADC value will not drop enough for us to see it. So there's 2 papers here that actually speak about this in correlation with with the pathology, which is key here. So there have been a number of studies that have looked at the potential of AI in prostate MRI and how they actually help with the tumors that we potentially physically cannot see with our eye. And so I've just put up 4 papers here. There's a bunch of other papers out there, but really computer-aided diagnosis may act in the future as an aid to what we're seeing with PIRADS. So PIRADS is a qualitative, non-quantitative, it's qualitative. You look at the images, you come up with a scoring system, but we're not measuring anything. We're not looking at how it differs from the contralateral side or the areas of normal tissue. This is where AI may actually end up helping us with the PIRADS assessment. So if you look at this paper here by Wang et al., no AI, all PIRADS 3. This was a small number that ended up being cancer in the PIRADS 3, but you can see when you actually put AI in here, it really differentiated the PIRADS 3 into those that were tumor versus those that were not tumor. So it separated things out a lot better, and there was improved discrimination of clinically significant from non-clinically significant cancers when you add AI algorithms into the mix. So it really, in the future, may have a positive impact on the triage of cases and on the efficiency of the radiologist. And this is important because, again, once the ISUP criteria is greater than 2, that is a Gleason 4+3, the patient needs to be treated either with surgery, radiation therapy, or focal therapy, depending on the case in question. And then those that are clinically insignificant, we don't necessarily have to worry about them. So lesion classification is really important for reduction in morbidity, getting rid of these unnecessary biopsies and treatment, and then in cost savings. So problem number 2 with the MRI is if we then identify the tumor and the patient goes for therapy, how do we accurately identify the borders, specifically for those who want to undergo focal therapy? So I'm now going to focus a little bit on this. So focal therapy is an option for treatment of men with clinically indolent or slowly progressive prostate cancer. It's because of men with clinically indolent or slowly progressive prostate cancer, they're at harm with radical whole gland treatments. So focal therapy can avoid the toxicity of whole gland treatment. But to make focal therapy really work, and to have the patients, benefit from focal therapy, we as radiologists need to have the tools to accurately locate the disease within the prostate and locate the tumor boundaries. So when we think of focal therapy for prostate cancer, you can do a targeted ablation of, if you have a tumor right here, you can do hemiablation of half the gland, and then even zonal ablation, so maybe 3/4 of the gland. So depending on how extensive the tumor is, but this all falls back on the visibility of the lesion on MRI because it's going to be MRI directed. So really the concept of MR guided focal therapy is based on the visibility of lesions on multiparametric MRI. Even if we're going to ablate with ultrasound and use some way of fusing the ultrasound to the MRI, we need to be able to see these lesions on MRI. And so when we think about the requirements, so for example, this is a tumor that's right here. And you can see that the little red here is an area that's going to be ablated. And over time, you can see that the targeted area, we get this large area of this was an ice ball actually monitoring intraprocedural MRI ablation, but you can see that it's nicely monitored. But again, you have to be able to see the tumor, potentially its boundaries, and make sure that we go further away from the boundaries to make sure that the entire tumor is treated. So MR, we need to be able to accurately detect indolent versus aggressive cancer, and then accurately define the tumor borders for it to work successfully, because we know that when we're looking for a recurrence post-ablation, it's usually along the peri-ablation margins that we begin to look. So defining these borders is key. If we look at the tumor microenvironment, this is just a general tumor microenvironment. So if you think of the green cells here being tumor cells, in a lot of different cancers like renal cell, you get these it's all tumor. In prostate, it's not so simple. It may be densely packed, or there may be interspersed normal cells, which we spoke about, which makes it very difficult. But on top of that, you also have these vessels that are growing out. So maybe the DCE is the way to go. So the tumor environment is kind of complicated. So we did this study, and others have done it as well. Just looking at that, if you were to estimate the margins of the tumor based on different sequences, so this is based on T2, DCE, and ADC, not knowing which one is correct. But if you look at them, this is the mean MRI-based tumor volume. Look at the differences here. So these are millimeters cubed. So T2 is 1073, DCE is bigger, 1314. Whoops, and ADC is much smaller, 790. So that's a big difference just in a mean number of patients. I can't remember exactly how many were in this study, but if you look at the mean volumes, you can see that there's a big difference here, and the standard deviation is quite big. In this specific study, we then correlated it with histological tumor volume based on whole mount. And look at this. This is the mean difference between the histology volume, which was depicted by the pathologist, and the MRI based tumor volume. So T2, the difference between T2 and the histology was 626. DCE, the difference between DCE and histology tumor volume was 280. And ADC, there was a big difference between ADC-based tumor volume, 3D based on 3D using 3D slicer versus histology tumor volume. So really the one that was closest, if you like, was the DCE, probably because of this microvasculature changes that are extending out. So the actual way that you contour the tumor, the sequence that you contour it on, where you can visibly see it with your eye, actually you may be missing parts of the tumor. So that's important to keep in mind. The other thing to keep in mind is that if, let's say, a patient comes in today and we outline the tumor, and then they're going to go and get treated. So we outline the tumor on our MRI images, and then we fuse them for ultrasound, and they get ablated, or we use MRI guided ablation. It's important to know that physiologically, the actual tumor may not be the same measurement if you measure it a couple of weeks later. So we did the study looking at the repeatability of it. So these were within a 2-week period, no interim treatment. So this is PZ, tumor region of interest, ADC subtraction and ADC, and T2, sorry. And this is the difference. So it was up to 42% difference in volume, and in a 2-week period. So this is important to keep in mind as well, that it's not so accurate. These are patients who did not have any interim treatment, and there was already a difference depending on how you contour it on a day-to-day basis. This, of course, has connotations as well, as that when you look to see what happens with follow-up in patients, you know, how significant is a difference if in a baseline patient there's actually a huge difference in a 2-week period. So really what we're contouring is not as accurate as we would hope. So what are the quantitative MR information that are currently evolving that could help with focal therapy down the line? So there are new options on the horizon. So we have what we have with the T2 and the DCE and the ADC based on what we can visually see. We have MRI, the qualitative MRI with PIRADS. We contour to the best of our ability, knowing that there's differences on the different sequences, knowing that if you repeat a case with no interim treatment, there's going to be some variability. And knowing again that AI may help us better define this. But what else is out there? What are people researching that will actually help us define the tumor burden? So one is these new sequences that are out there, looking at the tissue architecture with MRI. And another one is MR based or mass spectrometry correlation. So I'm going to first of all talk about these new sequences that are out there that actually try to look at the architecture of the underlying tissue. And that's actually quite possible with MRI. It's not your average sequence, but that's what people are trying to investigate. So if we look at this, we go back to pathology and we look at these 6 cases here. They all look extremely different to a radiologist's eye. Okay, so for example, here, let's look at the fuse pattern. So we have all these little cells, all these very, very dense cells, maybe with a little bit of stroma in the middle. Here's foamy pattern here. I guess this is the foamy stuff within the lumen here. Again, some dense cells, but they all look very, very different. Mucinous has all of this mucin kind of separating out. And then angulated. So we have all these kind of nasty cells, I guess. But, you know, even visually from a radiologist's point of view, when you look at these, they all look extremely different. And the pathologist would give them a different descriptive term. The problem is that every single one of these 6 cases are actually a Gleason pattern 4+3. So as radiologists, you can then see how difficult it is for us to be able to call some of these cases. So it may be that the fused are a little bit more easier to see than the mucinous, where we're getting fooled, if you like, by all this mucin that's building in there and maybe not making it so obvious for us. So a lot of people are out now trying to see, is there a way for MRI, because MRI is actually pretty intelligent. Is there a way for MRI to guess or estimate the percentage of lumen and the percentage of epithelial tissue? So I take Otto's group in the University of Chicago, and I'm sure there are other groups doing this as well, have looked at ways that you can estimate the actual lumen, the volume of lumen versus the volume of epithelium. So again, if we go back to our little diagram that we looked at in the first place, the volume of lumen here, you can see is pretty high in, you know, a tumor that's well differentiated or normal, because you've got these little holes, and the epithelium are just the cells outlining these holes. So in normal peripheral zone tissue, the epithelium you can see is 32% and the lumen is about 30%. However, as you head off to getting to more aggressive tumors, so we have Gleason pattern 3, 4, and 5, and just to compare, I just put all cancers here. You can see that the lumen drops significantly, so 30% down to 11, because the cells are up against each other and you lose this normal configuration. And then the epithelium doubles. And so it's possible that we can estimate that with MRI. So this is an example of one paper here from a while ago, and they've done extensive work on this since, is that you can actually get maps with MRI of the stromal volume, the lumen volume, the epithelial volume, and different sites have correlated this with histopathology. So knowing what the normal percentage of stroma and the normal percentage of lumen and epithelium is, and knowing what it is for tumor, potentially you can actually develop these maps on MRI and predict what the histology will look like. So this is something that's evolving, and you know, considering the maps that we get out of these new sequences, it's quite possible that AI will really help us depict exactly where these tumors will be and what the percentage makeup of the lumen and the stroma and the epithelium will be, and then help us predict what the pathology will be and where the borders will be. Another way to do this is, I think people may have heard of multidimensional diffusion MRI, or sort of looking at the microstructure, if you like. And really this is based on the fact that if you look at benign tissue here, for example, you've got a lot of the stroma, stromal tissue, which is kind of the light pink, and then some benign glandular tissue here. These are more malignant glands with maybe a little bit less stroma. This is a GG1, and then whoops, GG4 here is densely packed tumor nuclei. So you can see that this looks very different on a histology to this. So considering what we know about the percentage of stroma and how stroma actually looks to a pathologist, or architecturally how it looks, can we depict that with different ways of diffusion? And so just without going into great detail on this here, if you imagine we have a bunch of frozen peas, okay, so the cells are all frozen peas, the water molecules within the pea can actually rotate really in any direction. It can spin in different directions. So for the most part, the cells, these pea cells, if you like, their diffusion should be relatively homogeneous. If, for example, you look at rice kernels, so this would be the stroma the rice kernels are aligned in certain directions. The diffusion that you would extract from that with this microdiffusion techniques would be quite different to what you would see with the peas, where they can rotate or they can diffuse in any direction. And again, if you have a mixture of tumor cells, normal cells, angulated cells, this is your mixed veg pattern, if you like, the diffusion will look very different. So without going into the real physics of this, if you like, depending on the cellular shape and size and orientation, you can actually depict these microscopic diffusion metrics that will help you come up with a way of how the pathology is going to look. And so there has been some initial work in this, just looking at, you can, based on these metrics, these microdiffusion metrics, you can actually predict what the stroma is and what the amount of cellular tissue or stromal or glandular tissue will be. Not only can you predict what it will be, but you can potentially then figure out the extent with these maps of how far out these changes in the cellular architecture are, and then that can help direct where the borders actually are of the tumor. So while it's difficult for us to see this with our eyes, these maps from these microdiffusion techniques, you can imagine, again, if AI can go in and tell us where these borders are with the different maps, it'll help us give a better depiction of where the tumor begins and ends and what's the kind of cellular architecture that's there. And then finally, I just wanted to talk about real-time assessment with mass spectrometry imaging. So we all know that mass spectrometry, I think nicely, that the clustering, if you like, of this spectrometry of the different scores that you can get from it, that can actually correlate quite nicely with tumor. So here's a H&E section, and here are all the different metabolites that you can extract and measure with mass spectrometry. So what is nice is that in some centers now, you can do this pretty quickly. So at the site of the biopsy, little cells can be extracted up, and you can get a sample from here, get a sample from further out, get a sample from further out, and really define where the tumor begins and where it ends. And this can be done within a couple of minutes that you put it through the liquid extraction, get your metabolite readout, you know, in real time, more or less, and the level of the metabolites will differentiate tumor from normal. So again, if a patient is undergoing focal therapy, potentially something like spectroscopy, where you identify a couple of cells from the area that you're treating, it'll tell you where the tumor begins and where the tumor ends. So this is the sort of thing that's on the horizon to help with defining borders and specifically for focal therapy. So in summary, there are some tumors that we just cannot see with MRI. It's not that we're failing, just physically and qualitatively, we just cannot see them. And there is a reason for this a lot of time, in that there's dense and sparse tumors. And once the normal cells get in there and mix up with the tumor cells, it really fools the radiologist. AI may help with this detection. Accurate tumor border definition is a problem with the standard MR sequences, knowing that they're not so reproducible and that the actual volumes that we get, depending on the sequence that we measure the volume on, varies. And that's really important to keep in mind. And that there is a lot of work being done, a lot of novel opportunities to assess the prostate tissue microstructure, which really correlates with the pathology or the architecture with MRI, and also with mass spectrometry imaging, which can help potentially in the future define borders at the time of the focal therapy. And now Patrick and I will take some questions if anyone has any questions, and I'm going to stop share. Whoops.
Anybody is welcome to put questions into the Q&A function.
We have about 5 minutes if anyone has questions. Somebody did put a question in about CMEs. So the webinars do not offer CMEs, but you can put this as self-directed learning. But we don't actually have any Q&As and any CMEs. So there is a question in the Q&A about any tips for picking up central zone lesions. Patrick, did you want to address this? I think you had sort of touched on that. It's in the Q&A, not the chat, so I can see it. So
Yeah.
central zone lesion.
So as I said, the central zone lesions are quite challenging, and just argumenting based on pirates, the dominant sequence, as you know, is T2. But my first tip is to always correlate it with the diffusion weighted sequence, especially the high B value. So that it has to match on the high B value image, and do not overcall small lesions. So I think prostate MRI is not tailored to detect 2 millimeter, 3 millimeter cancer foci in the transition zone. So there needs to be a decent size of a lesion to make it conspicuous. And there's also tumor volume definition of significant disease. So do not overcall the small lesions.
There is another question in the Q&A. Is there any point in using curves for prostate cancer? So I presume by this they're talking about the DCE curves. We don't use those anymore. They're definitely not part of PIRADS, which is qualitative. And I think there's been, I think that there's been even a question about whether DCE should be part of PIRADS or not. I think it's a safety net for people who are a little unsure, but there's a big push at some sites to use biparametric protocol without the DCE at all, because it's much easier to get patients through. It's a shorter protocol. It's non-invasive. There's no need for contrast. And as Patrick said, the DCE, or it's mainly diffusion that's used for the majority of the tumors in the PZ. There's 2 more questions here. What do you think of prostate cancer screening by means of MRI? Did you want to address that one, Patrick? I think it's kind of what we covered.
Yeah. So there are in different countries different approaches to include MRI in an organized screening protocol. It actually is complicated. It needs a high knowledge of reading MRI, and obviously for screening you probably cannot use DCE imaging. So you have to use biparametric MRI. You have to assure that quality is high and that the readers are really experienced. And so there's actually, to my knowledge, only one country in the world that has included MRI in organized screening so far. So there's a road to go.
So that'll probably address, there's another question here. What are the positives of biparametric MRI to detect clinically? So the positives, I think we've gone through, but there needs, the people who are reading them need to be very well educated and quite confident in their reads. We did that one. Okay, so there is a question here. How effective is AI or other advanced techniques for identifying extra prostatic extension compared to standard MRI techniques? So again, I think it's the same sort of thinking, is that AI can really help differentiate or it has the potential to act as an aid to help us in picking up the tumors and then differentiating. When you think of comparing architecture, comparing normal architecture cells to tumor cells. And the same would go if there's extra prostatic extension. It should really help us define fat, periprostatic fat versus tumor. There's another question here about the importance of PSA density for detecting sparse lesions. So I know that PSA density is really important. The PSA density, for those who may have a question about it, is really taking into consideration the size of the gland, because you could have a large PSA in a small gland, which would be quite significant, or a small PSA in a large gland. So basically the size of the gland makes a huge difference. And I think it is important when you're looking for sparse lesions. It keeps your level of suspicion high, but it doesn't help you find them if you can't see them. So I think it is very important to keep that in consideration.
I would like to add, there is just one brief comment. There is a very useful table in the European urology guideline, which actually correlates or puts the PIRATE score in relation to the PSA density and helps you to make a decision on whether to biopsy or not. And so the cutoff is a PSA density 0.15 and even 0.2. So in the MRI pathway, it definitely makes sense to include the PSA density in biopsy decision making.
There's another question here about PSMA PET. Could it help in diagnosing sparse prostate cancer? I'm not a PSMA expert, but I would think it would not, simply because of the resolution of the PSMA. I think it's very good at looking for disease within the prostate, if you like, to confirm that there's a recurrence there or that there's disease elsewhere. I don't know if there's enough tissue there within these sparse tumors, if the resolution is high enough with the PSMA PET CT. I think we've answered all the questions.
I think so too.
And we're bang on time. We're 2 minutes over. So thank you to everybody. I think ICIS office is going to make these presentations available online if anyone wants to look at them again. And Patrick and I, feel free to reach out to us if there's any questions. So thank you very much for joining us today.
Yeah, thank you very, very much and have a good day. Thank you.
Okay, bye. And thanks to the ICIS office.